Get started out, let me introduce Dr. Rashidi. My name is Amir Bastaros. On the call today, we have Dr. Mark Solomon, Dr. Robert Cleary, and our guest presenter today is Dr. Layla Rashidi. Dr. Rashidi is someone I know very well. She was one of my fellows several years ago and is a really excellent surgeon, excellent robotic surgeon, and now is an innovator as well and moving into a program of her own in minimally invasive surgery. So without further ado, Dr. Layla Rashidi.
Thank you. Thank you, Amir. It's great to be here. Well, I am going to start sharing my screen. My topic will be about splenic flexure mobilization and intracorporeal anastomosis. Can all of you see? Okay, great. All right. These are my disclosures, but is not related right now to our talk. All right, so splenic flexure mobilization. When do we need to do it? Do we always need to perform splenic flexure mobilization? Well, not always to answer that question, but if you want to have a tension-free anastomosis during your rectal resection or sigmoid colectomies, or if you're doing a total or subtotal colectomy, you are doing a splenic flexure mobilization. For transverse colon lesions, that doing a extended left, that may be needed. So there are different reasons that when and why you need to do splenic flexure mobilization. Here, this is just the steps. I usually break down the steps for the procedure, and we're going to focus on the splenic flexure and intracorporeal. So as you guys know, first you get your access, you evaluate the anatomy, you place your ports. If needed, place your wound protector. You position your patient. I think that positioning the patient, especially for splenic flexure, is very important, and we'll talk about it. And what I usually do, I score from the mesentery, find the ureters and the nerves, ligate the IMA, and I usually perform my mesorectal mobilization, divide the rectum. Now, depending to how my anatomy is, do I need to do a splenic flexure mobilization? Do I need to ligate the IMV? And that's when I decide in that part of the operation. Then for intracorporeal anastomosis, we make a colotomy, place our anvil, and we perform our anastomosis, and we check for any leak and evaluate the blood supply and extract the specimen. So these are the steps, but as far as, the positioning we're talking about here, low anterior or sigmoid resections. This is a patient that I'm extracting from a fanning still. So we place the patient about 20 to 22 degrees T-Berg, and I usually roll the patient to the right side, about 14, 15 degrees. You want to target actually in the mid portion of where you're working. So if you're doing splenic flexure and going down to the rectal portion, you want to be in the descending colon. And as far as instruments, you will choose the instrument of your choice, but the instruments that I use on my non-dominant arm is usually the tip-up and bipolar grasper. And then we have our camera, and I usually use the monopolar scissor and the vessel sealer. And if you see the lesion, the target is there. Now, if I want to do a true splenic flexure, you may want to put your line a little bit more straight toward not exactly metagastric, but you want it to be more straight. So this way will allow you to do the splenic flexure more easily. And port placement, I'm sure Dr. Bastaros spoke to all of you with this topic, much more advanced than mine here, but just the key point is place the port about 6 to 8 centimeters apart, identify that target, and if you're putting an accessory port, make sure to be outside of your 2 ports and not in the mid portion of it. And anytime you're placing port, you want to make sure you have insufflation. So here, as you see, I have a straight line here. This is my dominant arm, number 4, 3 is our camera, 2, 1, and my accessory port. You can also put it up here in the right upper quadrant. And this way you can actually move toward the mid portion of the abdomen. Very, very important to get your patient clearance joint, but also this will help you, the flex joints, that you don't have any external collision. And here's just showing you that how do you do it. Let's say we're working in the lower abdomen. Now I want to get to the splenic flexure. So move those arms toward the area that you want to work. So I want to go toward the upper abdomen. As you see, our assistant is actually putting those all the way to the toward the upper abdomen portion. So this is how they just, and she's getting the clearance. So it's very, very important to change your arms based on the location that you're moving. Instrument we talked about, these are the main instruments I use: monopolar scissor, which is on my dominant arm for dissection, vessel sealer, and then stapler for dividing the bowel. The non-dominant arm, I like the bipolar forceps because you can actually use a coagulation on it, and both arms are working at the same time. And the tip up, especially in the pelvis and kind of with getting under the bowel, has helped me to kind of hold without touching the bowel portion. And here you can see we use indocyanine green to evaluate the perfusion, and use your bed if you have a motion table bed. This is our setup for pretty much all colon resection except the EA stapler, as you see, unless you're doing it right. So your entrance with your needle, I use the Varus. These are our 4 instruments, and your assist port, and monopolar scissor, and the tip of, as you see, the EEA, and our wound closure device. So these are very simple. You can replicate that, and it can make your life much easier. Use the tools in your toolbox. I'm sure you heard it from everybody. But use the ICG, you know, if you need it, in the ureteral stent to identify, you know, the ureters, and definitely use, you know, for evaluating bowel perfusion. As you see, the green portion is a perfused bowel, and the dark side is non-perfused. There are different ways you can do splenic flexure. Honestly, there's no one set way that say it's the right way. So there is a lateral to medial, which is the approach that I usually do, you know, for my cases, but it depends to, you know, what case you're doing. You can do a medial to lateral and kind of go supracolic, you know, go above, you know, where the transverse colon is, or you can do the submesocolic. It depends to how you were trained and how you like to do it. But there are important structures within the anatomy that you need to know. So definitely pay attention to this image. So there are attachments that you will see during the operation you take, you know, you remove. By your splenic flexure, you have the splenocolic ligament, which you kind of, when you do that, either from the supracolic or from lateral to medial, you can take that. The phrenocholic ligament actually is removed while you're coming from your lateral portion. And then once you want to get to this lesser sac here, which you want to be over this pancreas. So that's one of the structures that can get injured. And of course you have your stomach here. So you see there's a lot of important structure around that you don't want to injure: the spleen, stomach, and pancreas, and also the small bowel and vessels that we will talk about. I would just wanted to reiterate this artery of Moskowitz. It's very important in different patients. The anatomy is a little bit different, and if you don't know where that is, you can easily actually injure that and remove it, and that can cause problem with your perfusion. That has happened to me, I won't lie, which is, it's a very amazing outcome. You see the whole portion of the splenic flexure just dies in front of you. So watch out for that vessel. All right, this is also just the schematic of like how you approach. I usually get the IMA, do my lateral dissection, see if I need to take the IMV, and then, you know, take my splenic flexure. So some of the steps from lateral to medial, I think it's really important. You watch a lot of, you know, videos, great videos online, but I think for me, the most important was, how do I use my arms, right? Like what tool do I use to do what action? This is important. So I usually use my arm 1, which is my the non-dominant arm, pull the bowel kind of superiorly and ventrally, okay? And I'll show you that in the video. And then your arm 2, the other non-dominant, is assisting your, you know, the arm 1 to pull the bowel in a medial and collar position. Arm 4, which is your main arm, is actually doing the dissection. So that's very important. And your assist is actually pulling everything in a medial fashion. So it's really important to use your arm correctly. So here is kind of showing the which arms and what we do. So most important, you get in, you evaluate anatomy, flip that momentum over that transverse colon. Put your patient in a reverse Trendelenburg position when you get there. Get that small bowel out of your way to the right side. And then your assistant is pulling that colon in the inferior and kind of toward the midline portion. And like I said, your dominant arm is doing most of the dissection and your non-dominant arms are constantly working together. You guys are 3-arm surgeons, so make sure use those 3 arms together, okay? And then that's where we get to the lesser sac, and I'll show you the video. The reason I like this lateral to medial approach is, number one, I'm not encountering any major vessels, not really getting close to that pancreas, so kind of visualizing, everything before I move and then decide or if I need to do IMV dissection. This is just a traumatic kind of thing, how we pull that colon, downwards with your assistant and kind of getting around that we discussed about the phrenocholic and splenocholic ligaments. So this is just the first video I want to show you here, kind of showing like how, the arms are moving. So flip that momentum over, expose that transverse colon for yourself, move the, small bowel out of your way. Here we already did the pelvic dissection. Use all 3 arms. So you see, I use my tip up, I open the arms, kind of pull everything, toward medially and toward the head portion. You can tell the difference between the fat of the mesentery and what's, fat here in the Gerota's fascia. The yellow color is a little different, but you see my arms is constantly working together. So my tip up is pulling up, my bipolar is pulling medially, and my vessel sealer is constantly doing like the dissection and, kind of moving things forward. Here, I'm asking my assistant to pull the bowel back all the way down. So you see here, again, pull nicely with your non-dominant arm. And then here, your bipolar force that helps you. Let's say if I get to a bleeder or something, that can actually help me. And here where we get to that tail of the pancreas, right? So those are the structures you want to watch out for. And then that's the spleen right back there. So kind of when I get to that point, then I'm like, okay, now let me just take a little bit of that lateral portion. Then I go to my supracolic positioning. So here again, I'm asking my assistant to give me a little bit more tension so I can kind of start doing my dissection. Here now I'm going around. So that's where our phrenocholic and the splenocholic ligaments are going to come into place. And you'll see from this side, you can actually get to that lesser sac. So you can actually see the posterior wall of the stomach. And that's where right here, you see we're encountering it. And then you can do the rest of the dissection from the transverse colon. So as you see, just with one lateral, and one key important step, please medialize everything, okay? So don't do a little bit of a lateral dissection and still leave, the descending colon there. So medialize all the colon as much as you can toward the midline. Here's another video of, the different approach that we did here. We already did that lateral dissection. This was a pretty bad diverticular disease. So here, as you see, I'm kind of moving everything toward the head of the patient, and medially here, taking all those little attachments in the posterior aspect. So kind of cleaning off the descending colon all the way near the splenic flexure portion of the colon toward the midline. So take all of those kind of attachment, and you'll see we hit the important structures that we talked about, like the pancreas, which is here. And then again, try to clean as much as possible. So the more you do when you're doing your lateral to medial dissection, it will be easier when you go from the supracolic area. So here kind of is my point that I'm like, okay, I see the spleen back there. And I want to go now from the transverse colon side. So here you see I'm trying to get everything out of my way. I can. Patient is in the Trendelenburg. So take one of your non-dominant arms out. You need to have control over two arms when you're moving your bed, okay? So I have a dominant and non-dominant arm control. And here I'm asking the anesthesiologist to bring the head up. So in a reverse Trendelenburg fashion. So now you see the small bowel is all the way down. Here, use all your arms. So if you have an assistant, they can definitely help you. So I have my both bipolar kind of holding the bowel toward the head, and then the tip up is moving the colon down. And if you think about it, see how your port placement are. So if I want to actually have my, which sometimes when you get closer to the edge, you can actually have your tip up hold pretty much the momentum toward the head, but you're going to have some collisions if you do it in the mid portion of the abdomen. So always imagine how you place your port and how you can get less of a collision from outside. So here, as you see, we entered the lesser sac. We're moving forward. So kind of taking attachment, that's the posterior wall of the stomach here, and that's the colon downwards. Now here, I'm getting close to that edge of in the left upper quadrant where I did my mobilization from a lateral to medial. Now, once I get to that, as you see, it's kind of freed up. Now I'm gonna see pull everything downwards towards the pelvic portion. So this is the colon down, and there's just very minor attachment. And this is the spleen right here. It was pretty attached due to some inflammatory response due to patient disease. But here we're kind of moving everything down toward the pelvis. My non-dominant arm is holding the momentum and some of the mesenteric portion toward the head. This way I have tension, counter tension, and can get around this splenic flexure side. So pretty much taking some of the splenocolic over there, and now it's just minor attachment going to take, and we'll have a free flexure here. So so you see, we use two ways to kind of get that splenic flexure. So the next technique is medial to lateral, right? So in the medial lateral, your arm number 1 and 2, which are your non-dominant arm, helps to retract the colon upwards, and your arm 4 is doing the dissection. But one of your non-dominant and dominant arm are working constantly together, and the other non-dominant is holding the colon upwards. So you go all the way till you see kind of like that tail of the pancreas. Then you can move everything to the medial aspect and do your last lateral attachment. And then you can complete and reach the previous area by your transverse colon, how you saw we did it in the supracolic fashion. So here you divide your IMA. You have to be in this correct plane. So the mesentery of the colon is this yellow fat. The Gerota's fascia, like I showed you guys in the previous video, is this pale fat, okay? And this is a very nice avascular plane, and it can sometimes get sticky over that Gerota's fascia. And then you want to identify that IMV. Not in all cases you need to remove, but definitely if it helps you with having more reach, definitely you can remove. And for cancer purposes, I always remove. And then you do your blunt dissection. And like we said, take the mesocolon, and you have to be over the pancreas. All of the cases you saw, we were over the pancreas. You don't want to get under it, which is easy to get, and you can have injury to that area. And then the last would be your supracolic. So this is the area that I showed you in the last video you saw. So we had that mesentery here. We were pushing the colon downwards, and we were pushing the stomach toward the head. And this is another schematic that your assistant actually can help you pull this transverse colon down, and you can move forward toward the left upper quadrant. So this is just kind of showing you, how the arms are moving. This is just the IMA. You had a great video presentation with Dr. Solomon, so I'm not even going to go there. But here, I just want to show you how we're using the arms when you want to do that medial to lateral approach. So after you have dissected your IMA, right now my tip up, my non-dominant arm is holding the colon upwards toward the abdominal wall and toward the head of the patient. So now that, we have gone to that aspect, I'm going to bring my other non-dominant arm, my tip up, where you see my bipolar is helping. So this just helps to retract the mesocolon up, and using both my bipolar forcep and the vessel sealer to do the dissection from a medial to lateral portion. So you see this is kind of like this yellow fat we talked about, and this is the Gerota's fascia, which usually in the other video was nicer visualized. It's kind of this pale fat. So again, all arms working together. You're going to have your tip up go as you're moving upwards, your tip up is going to move up with you, and your vessel sealer and your bipolar forceps are constantly going to be doing the dissection. So you see there's not much grabbing the bowel, and I think that's important. You're just retracting. You're retracting and you're moving pretty much lateral and upwards. And I think practicing less grabbing technique, it helps with your patient outcome from an ilia standpoint, from intraoperative problems such as injury to the bowel. So I really recommend kind of trying to grab the bowel less and try to do more of a sweeping maneuver action. So here, that was our medial. Now we're going to start performing from a lateral aspect. So I'm not sure, can anyone ask questions, or is it going to be at the end of the session, guys?
It's however you want.
Okay,
We've been asking
seeing
people to put the questions into the chat.
Yeah, would you guys?
So if you want to pause and take questions now,
sure, I want to do that.
And what do you want?
I think we can do that, and then I can go to the ICA. So
okay, I'm going to start while they start typing their questions. Let me throw one out there for you.
Sure.
For those of us that are poor and don't have table motion,
yes.
Have you found trouble with the lateral to medial approach?
Yeah, well, I didn't have table motion till actually last year or so, I would say. I would, it depends to your patient body habitus, but most of the time what I do, I rotate the patient all the way to the right side. So that helps you get the small bowel out of the way. The main question becomes in that left upper quadrant when you want to take the colon. So what I usually do, I flip that omentum like I showed at the beginning of the case. So this way my transverse colon is exposed. And I put the patient about 20 degrees Trendelenburg. Most of the time, I don't have any problem, but I think the key is at the beginning of the case, set yourself up. So flip that omentum, find that transverse colon, push all the small bowel to the right side, because you can actually move the, your bed all the way to the right, and then go. If worst scenario, you're up there and you really can't see anything, then you have to undock and change the bed position. But 90% of time, you don't have to.
Yeah, I can tell you 100% of the time, if you're positioned properly and get yourself set, you don't need to get them out of Trendelenburg. But we have a question from Joel Collefeld. Do you take the IMV with vessel sealer?
I do. I take all my vessels with a vessel sealer. I think it's really important how you use that vessel sealer. I'm a little bit more conscientious. So I do 3-4 at the, from a coac perspective at the proximal portion of the bowel, then 2-3 at the distal. And then I go in the mid portion and do about 1 or 2 with sealing, and then I cut. And I've never had issue with bleeding, even in a lot of patients with Crohn's or really bad kind of a friable mesentery. But I think you got to use your vessel sealer with care. It's not like one sealing and one cutting. You have to.
Have you ever had trouble with calcified vessels?
Yeah, I have.
What do you do in that setting?
In that setting, what I do, I have an endo loop in the room. So what I do is I get the exposure of the vessel. I use my vessel sealer, and then I put an endo loop around that vessel. So you also can use a clip. There are robotic clips that you can use, but endo loop is usually cheaper and it's right there, and I use it.
Actually, the robot clip is very inexpensive. It's about $10 a fire. So it's
nice.
not expensive at all. So
here we go.
One other option.
You can use it. Yeah.
Are there more questions from the panelists before you move on to the next phase? Seeing no more questions in the chat, I'd say go ahead.
Don't be shy, guys. Ask any questions. I love the
clips. They just fall off sometimes.
Well, it can. Don't let it fall, I would say. All right. Well, I'll go to the ICA, and then at the end, please bring your question. Don't be shy. This is a place to be, and, you know, ask any questions you have.
You know, one thing I noticed is that when you do clip,
yeah,
you burn. So you clip, and then you burn in between the clips. That thermal injury, a lot of times will have the clips just fall off.
Fall off.
Yeah. So I kind of avoid either doing too much of a thermal burn or whatever in between clips when or if I ever, and I very rarely use.
What do you guys use? Do you use vessel sealer all, or how do you guys?
I burn the life out of the vessels. Like if
Me
here's
too.
the vessel, I'll burn it until like it's basically clear. Once it's
Mine
clear,
is black.
Yeah,
That's what it is. Yeah. That's why I say you got to use it multiple times.
exactly.
I use vessel sealer on all the vessels. Before I cut any named vessel, I make sure that it's sealed.
Yep.
I would caution, there's something a lot of people like to do is burn the same place twice. That's actually quite dangerous because you denature your seal that way, and you can actually cause a rupture. But more important than burning in multiple places is to spread your burns so that you have a wide area before you cut.
See, I don't know about that, Amir. I mean, like, I hear what you're saying, but I think that, hello, how are you? Yeah. So I think she's gotten big, man. She's really big.
Yeah.
Oh.
So, you know, I think that what you're talking about is banding, is when you burn something in one spot and then you separate it, and then when they don't overlap, that banding, that's what causes weakness of the seal. But if you burn in one specific spot, my understanding, then it's fine. Regardless, that's what I do. I'll burn it like 4 times in one spot and then check it. And
but most of the manufacturers tell you not to burn the same place twice. So I just would caution you about that. I have seen it denature while I'm watching it. So just be careful.
I'm not sure what denature
I usually
means.
do.
It breaks down the bonds that you just created.
Sure. I mean, I think that's a thermal thing. But I think if you don't have, I hear what you're saying, but I preach burn it to its death, but with no tension. I think is important. Yeah. But do whatever's safe.
Yeah, I do kind of in between you two. So I burn the hell out of it, but I do the first one, then go a little bit higher, then come back, and then but it's pretty much the same region. But yeah, I agree. Burn it. Don't just do it once. I think that's the message here. All right. So
and clips are good for calcified vessels. Clips are quite good, and they're inexpensive, and the robot's right there. And I prefer it for calcified vessels.
Yeah. I would say the only thing is if you see sometimes like you really didn't do a nice cleaning around the vessel, because that's when you can place the clip, or you're just not able to, then I would say have that endo loop in your room. I have it all the time, especially in bad Crohn's patient or redo cancer operation with radiative fill. So just have that in the room. It won't hurt, but definitely clips is a great tool to use. So use all those tools we discussed about. All right, so the next one is intracorporeal anastomosis. And I think this is a hot topic because everybody keeps talking about it, and everyone is doing it differently. So it's just, I was just gonna show you some of the things I do, and I'm sure the group we have here, I'd love to hear how they do it and how you guys do it. So there's different ways. You know, if you're not using the EEA, you're doing kind of a bowel to bowel, you either doing the anti-peristaltic or isoperistaltic. I personally do isoperistaltic, but it depends how your bowel is kind of coming together, like your transverse colon to, let's say, your sigmoid, or, you know, descending. For right side, I always do isoperistaltic, and I know Dr. Clearly is going to give an amazing talk about right colon, so he'll go more into how those anastomosis are. And then as far as, you know, your lower anastomosis, you can do either end to end or end to side. With intracorporeal, I tend to do more end to side, and I'll show you why and how it's easier. But there's definitely different ways to do it. So these are some of the instruments you will need, okay? So you need that wound protector if you're doing extracting from the rectum, or if you're actually extracting from the fan and steel area, which that's where I use a small or extra small wound protector, depending to what disease process is. Dilators definitely use, and your EEA. It depends which company your hospital has, so there's no difference between them. When I'm doing the NICE procedure, which the extraction from the rectum, this is my setup. Pretty much, I have a coker, which is attached to that wound protector. I got my anvil, our long Babcock, and the EEA dilators. So those are the things. And here, the types we talked about, you can do extracorporeal, which you do everything inside the body, make a little fan and still or a midline incision and bring the colon out that way. And you can do intracorporeal. To be honest with you, I'm a little biased. I'm like, well, you're doing everything robotically. And honestly, since I have started doing intracorporeal, less and less and less I need to do splenic flexure mobilization, because you don't have to pull that colon all the way to the abdominal wall, which you don't know if you have a 400-pounder patient, you got to pull up quite a bit. So that's why I thought this anastomosis, it kind of goes with splenic flexure, because not a lot of time you need to do it. So this is, so the way I do my intracorporeal, so I already did the lateral mobilization, medial, the rectum has been divided. So everything has been set here. And I always put my wound protector at the beginning of a case if I'm extracting from the fan and still area. So my tip up, you see, is holding the colon all the way up to the abdominal wall and toward the pelvis. I put my anvil from the beginning, where my wound protector is. So be efficient. Don't waste time. Ask your assistant to give you the wound protector. Then I use the ICA. You saw I cleaned the mesentery up where I took that vessel. I made a little colotomy here, and 4 centimeters down, I made my larger colotomy to put my anvil in. So right now you see this is a smaller one. It's about 4 or 5 centimeters to the other one. And then I push it in, grab, and then pull it up. So you go from the end, which usually has the spike in it, but I don't use the spike since we do the colotomy. And then you use we have a 60, 45. I usually use 45 because down in the pelvis is a little narrow. And so I use the 45 green load stapler. I like to put a little purse string, around it. So as you see, I use my vessel sealer to put my first. But then for the second one, I use my bipolar, because you will notice when you want to put the other string on the left side, it can be difficult and you're going to have some collision. So then you put your purse string around that area, and then kind of put your EEA from the pelvic area and your colon down and do your EEA test. Now, if you're doing a natural orifice intracorporeal anastomosis with transrectal extraction, it's a little bit different. So I don't make that fan and still, incision. Here you see, first you have to clean the rectum. I like to clean the rectum actually starting from the right side and kind of marching around, going to the posterior aspect and then to the left. So you see I made a little nick here. So, and then I started from this right area, start here and then start dissecting, from the lateral side, get to the posterior, take the mesorectum off, kind of clean it off nicely. So you see my non-dominant arm, my tip up is actually holding the bowel all the way back. You can have your assistant to do that if you need, and my bipolar is kind of helping, to retract the colon up. So here, I'm sorry, I actually have my tip up holding the uterus up, and then my assistant pulling back and using my bipolar, my other non-dominant, to kind of give me more retraction. So you see nicely, I start from right side, getting to that posterior aspect, cleaning it completely up, and then getting to the left lateral side. You see, with one move or one position, you can get all around. Now, if you have a very bulky colon or rectum that you can, then you want to move your arms to the right side and kind of see that left lateral portion. But be systematic, don't babble, go right and left. Start from one side, go to the other. So now here you see I'm bringing the dilator in. So my assistant or a resident is putting the dilator all the way into the rectum, going in and coming out. So here, you see I used the 29 and then I went actually to 33. So I used a large one because the rectum is gotta come out of there, right? So I try to dilate as much as I can. Then I'm gonna, so once I did that, I'm not gonna cut anything. You don't wanna get contamination. So again, you see tip up is holding the bowel all the way toward the pelvis and abdominal wall. So nicely exposing that mesentery for me. And then I'm using the bipolar forceps to kind of give me a little bit more traction toward the head of the patient. And with a vessel sealer, I'm going to start, doing the division of the mesentery. And then again, same story, start with one side, go to the other side. So you'll see the right side is in front of me. So I'm going to start taking the mesentery from there and then kind of moving back posteriorly. So and usually in this setting, if I'm going from one side to another, I rarely have to go back and forth, which counts on your inefficiency if you keep doing that. So now that we cleaned it, I'm going to come and divide the rectum. So I use the vessel sealer to, I don't use the coag very much on it. So I use mostly cut and a little coax, so not burn the edges, even though I'm going to staple off that edge. Then our assistant from down below is going to give me that small wound protector. So put that Coker-C at that tip of that white portion. So that's where she can give it to you. And then once you see it, grab it and pull it toward the pelvic portion. Then get the anvil from the rectal portion. Here, our division is here. I went about 4 centimeters, so you can actually open the bipolar jaws, and that's a measurement. It's about 2 centimeters each of those. So come up, and then here you see we push that in. Here I had my tip up was sitting there, so just grabbed it, and then with your bipolar forceps, pull the rest of the colon down to kind of flatten for yourself, and then divide it. I have to say, as far as it depends which EEA you use, stapler. Covidien is thinner, so it's easier to grab. Ethicon is not, so I found the tip up holds the anvil easier, or actually the clip applier holds the anvil very nicely. So if you see you keep, having problem with that, you can use those instruments. Here we extracted the specimen and then have pulled the small wound protector from the white portion, and my assistant grabbed it, and it comes out easily without any injury. And then I just divide that and I pass that through our 12 stapler side, which comes out very, very easily. Some people actually do suture that part or place a little purse string. Depends what your comfort level is. I feel if I'm less in the operating room and spending less time suturing, that's better for the patient. And actually, even with the cost, if you look at the cost in the OR, but there's nothing wrong with however way you want to do it. You can actually do a purse string with a V-lock and instead of using a stapler. And then here, I'm just, again, you see, I give that, I use my bipolar to put the suture on the upper portion, just because with my vessel sealer, I'm going to have problem with collision. So use your arms. I mean, you're a 3-arm surgeon now. You can use your right arm, left arm, pretty much whatever you see in front of you, make it easier and less collision for you. And then again, here we go. We're going to do our anastomosis. So, which I usually give an ICG, and also I do flexible sigmoidoscopy on all patients after doing the anastomosis. This way you can look inside the lumen, but also check for leak. This is just kind of, this part is fast because I want to get to the part of the colostomy. This is a colostomy reversal, just showing you different ways, to do things. So this was just the rectal stump. I cleaned it out and just stapled it. So that part has been done. Now this is the colostomy. Here is just fast because I want to show you the anastomosis. Just clean it up, which you guys know how to clean it. Now here, again, I'll have our assistant put the dilator through the colostomy. So we dilate, then I'm going to know where I'm going to staple off and where to make it. So here I'm stapling here, made my colotomy here. Now they're passing me the anvil. So, and then I staple it off right there. So this way it saves you time. You don't have to do the dissection, then come to the abdominal part and take the colostomy down from the skin level and put the anvil in. This way you're doing everything inside the body. Again, all the dissection prior to doing this part has been performed. Splenic flexure mobilization, you know, pretty much all the mobilization has been performed. Here I'm just showing you that how it can fall. So I'm using the vessel sealers, and here we go. Can't grab it with there. So then I use the tip up, which is a very good instrument to hold that. If you're using an Ethicon EEA, I will say that's one of the good tools with your tip up to use. And then again, same story, use your ICG and evaluate your anastomosis. Some of the complication with when you're doing a splenic flexure mobilization, you know, you saw the structures around. So splenic laceration is a big one. So be careful for that. If you're going too lateral, you saw where the ligament to the diaphragm is, you can actually injure the diaphragm. So I don't know how you can really get up high that high, but that can happen. So watch out for it. That tail of that pancreas. So one of the key factors, hopefully you got from this lesson, stay above the pancreas, or when you see it, stop at that level, then do your supracolic. So pancreatic injury and leaks are very, very common if you don't notice that pancreas, the tail of that pancreas in your way. Gastric injuries, as you saw, we enter the lesser sac. So make sure you don't cause any injury there. Duodenal injuries, in one of the videos, I show you where that small bowel was as we were doing our lateral to medial. You can actually get to hit the duodenum, and of course, vascular injury. So I wanted to leave some rooms for questions, but it was an honor to be here with everybody. And this is about 2 years ago, guys, right? Dr. Solomon had to catch a flight, but this is Dr. Cleary here and Dr. Bastoros. We had really fun in that. And Dr. Solomon was here, but he had to leave a little early since lives in Florida to catch a flight. So, all right.
Thank you, Dr. Rashidi. We do have some questions. We're going to jump right into it.
Sure.
Going back to, so there's a question here about the NICE procedure. Do you do it with cancer surgery? Is it only benign disease?
Okay, so far, I don't have enough data, so I'm not doing it for cancer. I'm just doing it only for benign disease. And one of the reasons is you are opening the bowel, you are exposing. So I personally do not do, but I do know surgeons who are doing for cancer. Do you guys do it for cancer? All the panelists?
Done it, but I don't really enjoy the NICE procedure. It's just
I don't either.
Yeah, it's so painful doing the transanal extraction that that's just painful.
I worry about patient, especially if you got a bulky, whether it's diverticulitis or cancer, a bulky lesion, you really risk incontinence with the patient. It's for a male pelvis, it's hard to deliver it, you know, and yeah, I'm not a big fan of it, but you know,
I think you have to be selective. You're right. Not for cancer, not for bulky. I mean, if I see something is like a rock and bulky, no, because you don't want to tear the rectum. It's very easy to tear that rectum, bringing it out. So I think you have to be selective when, you know, when I show this NICE procedure, is not like every case is NICE. It's, I'm selective. I know there are some that are not selective and they do it for every, but I agree.
So the question about doing it for cancer or not cancer, my argument would be that, you know, in every situation you're transecting the bowel. So if you're worried about cancer spread, you know, if you've got a bowel prep, you've got cancer cells that are going to be everywhere in any hole you make anyway, whether you're doing it extracorporeal, intracorporeal. So I think as long as you're not having spillage, gross spillage, you're probably as safe as anything else. I really would like to see a study that would tell me otherwise. Continuing on, we have, let's see, Dr. Rebecca Rowan asks, what suture are you using for the purse string or on the anvil?
Yeah, so I just use a 3-0 vicryl suture. And that the reason I use it is just because, especially for your low connection, if I have a little like opening or so from that from the colotomy I made to place the anvil, I just want to make sure I secure it, because when I get down to that pelvis, sometimes you can't visualize, you know, what's happening on the anvil side. So yeah, I cut the vicryl to 6 inch. It's a 3-0 vicryl, very simple. That's what I use. But if you want to, the purse string we talked about for the rectal part, I don't do that personally, but I think your best would be one of the barred suture like V-Lock or Stratifix to use. But for my anvil, Vicryl.
Do you put a purse string every time around your anvil?
Most of the time if it's low, but if it's not and it looks great, it has nice and tucked, then no, not always. So it's very selective.
Yeah, you're much better than I am in terms of planning where you're going to put your anvil, because I can never judge that well. So I end up doing it in 2 steps. So you're better than I am at that.
Hey, I learned from you, by the way. So I don't
changed
really
my
go
technique.
with that.
You're better than I am. I'm really impressed with your technique. It's wonderful. I always learn from you guys. Dr. Sung Lee says, when do you medial to lateral dissection? Do you keep patient in Trendelenburg position? If so, what is usual degree?
So the degree for the Trendelenburg, so I actually set up the patient at the beginning. Like Dr. Besteros also mentioned, set yourself for success. So I do about 20 to 22 degrees Trendelenburg and about 13 to 14 degrees to the right side. That's the position I start with. As far as the medial to lateral, it depends. Like if I took the vessel and I see a nice, it's pretty much for me selective. I do mostly lateral to medial, like I mentioned in my talk, but I will keep the patient in that position for the medial lateral position the whole time. And honestly, rarely need to change the bed. There were that incident like that video I showed you, I just couldn't get exposure when I wanted to get to that splenic flexure. Then you can change it. But 90% of time, or even 95% of time, you're good with that position you put the patient in.
Dr. Mohammed El Fayed asks, thank you. Any tips for targeting to get both splenic flexure and rectal dissection in one docking?
Absolutely. The first few slides I showed, which hopefully will be available to you guys, you don't want to be too flat with your port placement. You want your port placement to be kind of diagonal. I would say aim for higher. So if, let's say, left upper quadrant was going to be my non-dominant arm number 1, come more toward the epigastric. So instead of being kind of a sideway, you want it to be kind of straight. I go about the 6 to 8 centimeter we talked about. I target the mid portion of the 2 area we're working. So most of the time is a junction between descending and sigmoid colon. This way, I have to tell you, I mean, I have videos, it's kind of funny that sometimes I had to do a hepatic flexure mobilization, even like going, and you won't believe it, by moving your arms like we showed, you can get all the way to even the right side. Well, try the hepatic flexure side. So yes, just do it in the mid portion, descending sigmoid colon. That should be your target. You can go as low as literally the levators and up as mid transverse colon. Is that how you guys do it? I would love to hear where you guys target.
No, that's accurate. I think I would caution only is that if you're too vertical, you'll have trouble with internal collisions in the pelvis. So keep an eye on, in that situation, you might want to drop your right lower quadrant further to the right. So again, you're facing your workspace at all times. What about the rest of you?
I hate targeting. So
yeah.
Yeah. So
it's hard to teach not targeting though.
Yeah. Oh yeah. I mean, I guess, but yeah, you're right. Oh, the courses will show you guys, but
agree with it. Target for now.
Okay, Dr. Rowan says, thank you. Also wondering why you prefer the end to side in this situation. I think she's talking about...
yeah, so if you want to do end to end,
suture.
then that means you're talking about, I think, the ICA, the intracorporeal.
Yes.
So I mean, it's much easier, it's much more efficient because you're making a colotomy, which you're bringing that anvil in and you're stapling it. If you want to do an end to end, you have to cut the colon completely, either suture it or place your anvil with a spike. You can do that, use the anvil with a spike with a little string to it, and you can actually put it in and pull it out and do like an end to end. To me, this has just been easier, faster. I mean, we can do an ICA in less than 5 minutes with this technique. So I think it's surgeon's preference, but from an outcome standpoint, leak standpoint, no difference.
Yeah, I like the side to end because you have fewer crossing staple lines, but you're absolutely right. You can do the same thing end to end with a purse string on the end of your bowel, or an endo loop some people do. Both of those are fine. You can even hand sew your full anastomosis without any staple lines. Do a double purse string, or you can do a hand sewn anastomosis, all of which you can do robotically relatively easy.
Yeah, absolutely. Anyone does hand sewn here with, no?
I've done quite a bit. You mean hand sewn for a fully hand sewn anastomosis?
For
Yeah.
the low anteriors, not right. Yeah.
Yeah, for sure. Like I've done probably about, I don't know, 15, 20 of them.
Why do you like that? How long does it take you?
About 15 minutes is not too bad. I mean, it's just when I'm bored or something happens. And
Can you say which suture you use for the fellow?
Sure. So the back wall, I'll put a running suture line of 2.0 Vicryl for the posterior wall, and I'll take 2 3.0 V-locks starting at the posterior midline and running one in either direction around, and then the anterior wall I'll just reinforce with it. Basically, it's a running canal. I actually have a YouTube video on this exact anastomosis. So if anyone wants to take a look at my YouTube channel, that's youtube.com/Mark Solomon. And then it's all about the fully hand-sewn EEA anastomosis. So, yeah.
Yeah, you have amazing videos. I watched them too. So, yes.
Next question is again from Dr. Joel Calafell. I really like your technique for the end to side. What arm are you using to push the anvil through your colotomy? And does your arm selection change Covidian versus Ethicon?
So that's a great question. And I think, your question is right on, like, how do you use those arms, right? Because everyone does it, but how do you use it? So the arms that I use to push the anvil, we have the Ethicon in our hospital. I would say if you have Covidian, you won't have problem using any of your arms because it's thinner, the anvil portion of it, the metal portion. Ethicon is not that way. So I have found the tip up is actually very easy to handle that anvil. Now, when we're doing the actual placement of the anvil, as you saw, I have my tip up holding the colon, making the colon straight. So pushing it all the way to the pelvis. Then when I make that colotomy, I still have my bipolar forceps. At that time, I have monopolar scissors. So I switch that monopolar quickly to vessel sealer. I don't open another instrument. So I get that anvil and use the bipolar because it's a short distance, put it in there, and then my vessel sealer helps to push it to get it to the other colotomy site. Now, if I have, in this video, I didn't have any problem grabbing it, but if you have problem grabbing that anvil side when it's coming out of the bowel, get your tip up. So let the bowel go and have your tip up pull that anvil up for you. So I have found the tip up works very well for Ethicon stapler. For Covidian, we don't have it, but just the practices I've done, there's no difference in what you use. Another instrument, as Dr. Basters mentioned, is not very expensive. You can open, I guess, the clip applier. The clip applier can hold that anvil nicely too.
Yeah, I would, for the Covidian EEA, the manufacturer recommends not grabbing any part except the white plastic portion. So you have to be careful not to squeeze too tight to disrupt the ridges on it. But there is a smooth part of the central collar that you can grab. I agree. It's very difficult with robotic instruments. And the one I find to be most reliable, whether it's Ethicon or Covidian, is the clip applier. However, they did change the software on the robot a couple years ago, making it a little bit more cumbersome to use the clip applier because you have to release it and roll your grip and re-grab if you move the camera. So you have to you get used to that now that when you know that that's going to happen, so that your left hand can support the anvil if you need to move the camera. But otherwise, the clip applier is excellent because you can go metal to metal and really not going to disrupt anything. And it's solid. I don't use the clip applier. I use the double fenestrator, where they call a small grasping retractor. It doesn't have quite the grip strength of the tip up, but it's longer, and it allows you to be able to manipulate the clip, the anvil pretty well as well. What do the rest of you think?
Yeah, I agree. I use the clip applier and have the same issue with the camera. So I try to keep everything in the field so I don't have to readjust when moving the camera. I use clips during the procedure anyway, so instruments always readily available to me.
I find that the vessel seal extend fits right down the shaft of the EEA anvil. So that's pretty much what I'll use, and I'll just fumble around with it until we get it done. It's not that elegant. I've definitely used the clip applier, but like what you said, Amir, once they changed the software and you have to re-rotate every time and it drops it just got too annoying. So I went back to vessel sealer.
We only have a couple minutes left and we still have a couple questions. So I'm going to quickly go through here. Dr. Mohammed El Fayed asks, for a nice procedure, do you grab the white end of the Alexis or the green with the coker?
So the white, don't do what my fellow did to me. So if you get the green part in, you're gonna have a misery taking it out. So grab this. So what you wanna do is get your coker, grab the white portion, pull the wound protector back so that will straighten it up. And then remember, dilate the rectum and then push the white portion in. So the green should be outside in the anal area, which you can visualize it. And then the white is coming toward the rectum. Once you push it in, the surgeon or yourself see the white, ask the assistant to push it more and then get a good grab on it. Once you got that grab, let go of that coker, okay? And then you can push that white portion in. The reason is easier because getting the green part, it's a little bit firmer out of the rectum, it can cause injury. I had that problem. I did that by mistake and the green was in. There was no rectal injury, but it took a long time to take it out and it can be really miserable. So once you want to take out the wound protector, what you want to do is give that white portion to your assistant, which has the coker in, and they just grab that with their coker and easily pull it back. So the white portion has to be in, the green out.
All right, next question from Dr. Sung Lee. For transrectal extraction, do you use rectal irrigation prior to dividing the rectum or do you just do bowel prep?
I do bowel prep. I do scope my patient kind of before it for the low lesions. So sometimes I irrigate with that, but no, I don't. Not always. But it's a good practice to do if you guys are already doing it.
Dr. Hanju Lee says, is there a way we can have access to the video you posted in this presentation? The video is often choppy at times. I'll answer this. We're going to post the entire presentation at the program director's website for you to be able to watch.
Yes.
And we'll see about the actual videos. It's a little bit more challenging, but we'll think about.
And if you want, my email is there. Just contact me. I can send you guys the video through your Dropbox. So just let me know what you want. I can send it to you.
And then Dr. Alton Sutter says, maybe I missed it, but is the colotomy for anvil insertion on specimen side still open at extraction?
Yes, good catch. So yes, so there's a small colotomy and the big one that you guys saw. So I staple actually proximal to that. So you still have that colotomy side on your specimen side. And if I leave the specimen in to do the anastomosis, I just get a vicryl suture and close that colotomy so I don't have any spillage. Or if it's a small lesion that we're taking, if it's transrectal, well, it's going to come out. If it's through our fan and steel, I put few sutures and just leave it on the side, do the anastomosis, and then take it out. But good catch. It's on
I don't know about everyone else. I leave it open. You close it with your grasper as you take it out through the fan and steel, but I don't think it's wrong to close. Last question, because we're really running out of time here. Thank you for your talk. If you have a leak on your ICA, do you redo the ICA or do it extracorporeal then?
Depends. If it's a big leak, yes, I redo the whole thing and I have done that. If it's small, I can oversew it. As far as going open, rarely. I think it's easier to access with the robot with your visualization and just even redoing the whole thing. So stay, if you feel comfortable performing it robotically, stay robotically. And the leak is just depend to the side. You can go as smaller as just oversewing and rechecking. Sometimes you may need to do a proximal. If you have a very, very low anastomosis and you're still worried, you can always, protect it with a loop ileostomy. But if you have good access and you can check it, then you can just repair or redo it. What do you guys do?
Yeah, I say robotic. You're not going to be better extracorporeal. You're not going to reach further. You're going to have to do more mobilization. Just continue with what you've been doing. Either repair it or redo it. Yeah. We've all been there. Well, thank you, Dr. Rashidi. That was amazing. We're really glad to have you join us as faculty. We thank you all for participating. Dr. Cleary, Dr. Solomon, do you have anything more you want to add? I know we're over time already, but any words of wisdom?
Oh, great presentation, Dr. Rashidi. Really enjoyed it. Next month, May 16th, Dr. Jamie Cannon from University of Alabama, Birmingham will be talking about TME.
Dr.
Great.
Solomon?
No, great job, Layla, as always. And I think if there's one message to send out to the crew that's listening, record and watch your videos. Probably some of the most important things that you will ever learn is you as this case study. So please watch your videos and be critical privately be critical to yourself and see what you can do better the next time around.
Absolutely. I 100% agree with that. I was a fellow of Dr. Basturas, made me do watch all my own videos. And then I learned what the value of it is. And right now I record every single procedure I do and kind of go back and see how I can get better. So definitely do that. That's a very important message.
Well, thank you all. And thank you again to Intuitive for sponsoring us. We really appreciate the support, not only for these webinars, but for the courses themselves. And thank you to Dr. Cleary, Dr. Rashidi, Dr. Solomon, and all of you. See you all soon.
Take
Bye,
care.
guys.
Bye.
Take care.